in case.
All right, I'm going to say order, hoping that all the phones are caught up. I call this meeting to order. This is the Standing Committee on Health. I'm John M. McDonald, the MLA for Hants East and the chair of the committee. Today, we will hear from Nova Scotia Health, Doctors Nova Scotia, and the Department of Health and Wellness regarding ER closures and doctor retention. Please put all your phones on silent. Now I'll ask the committee members to introduce themselves for the record by stating their name and constituency, and I'll change it up. I'll be starting with MLA LeBlanc to catch her off there.
Good morning, good afternoon. I'm Susan LeBlanc, the MLA for Dartmouth North.
Hi, I'm Gary Burrell. I represent Halifax-Chebucto.
Good afternoon and welcome. I'm Rafa Di Costanzo, the MLA for Clayton Park West.
They acknowledge you.
Oh, there it is. Okay, I didn't realize it was on. Kelly Regan, MLA for Bedford Basin.
Hello, Danielle Barkos, MLA for Chester St. Margaret's.
Good afternoon, everyone. Chris Palmer, MLA for Kings West.
Good afternoon. I'm John White. I'm the MLA for Glace Bay and Dominion.
Yeah, good day, everyone. Nolan Young, MLA for Shelburne.
For the purpose of answers, I'll also recognize the President of Legislation Council, Gordon Hebb, and Legislation Committee Clerk, Judy Cavanaugh. Welcome witnesses. I'll get you to introduce yourselves first. I'll go from left to right, and then we'll do opening comments after. So I'll start with Dr. Colin O'Dane. How'd I do? All right, thanks.
I'm Dr. Colin O'Dane. I'm the president of Doctors Nova Scotia.
Dr.
Nicole Boutlier. I'm the EVP of Clinical Operations and Medicine at Nova Scotia Health.
Ms. Oldfield.
Hi there, my name is Karen Oldfield. I'm the president of Nova Scotia Health Authority.
Deputy Minister Lagasse.
Good afternoon, Janine Lagasse, Deputy Minister of Health and Wellness.
And Associate Deputy Minister Craig Beaton.
Good afternoon, Craig Beaton, Associate Deputy Minister, Department of Health and Wellness.
Okay, so I'm going to wonder who's going to start. So we're going to start with Ms. Lagasse. Ms. Lagasse.
Thank you, Mr. Chair. And thank you for the invitation to appear here today along with our colleagues from Nova Scotia Health and Doctors Nova Scotia. I first want to recognize the many healthcare professionals working in emergency departments across the province. They are highly skilled and work incredibly hard to support and care for patients with unexpected or emergency needs. I want them and you to know that we are committed to supporting healthcare professionals and patients to receive even better care. More, faster, Mr. Chair. We have heard our Premier and ministers say this many times. Delivering more care, faster care, means we must take a whole-of-system approach. This includes emergency care. A change in how we deliver care in one area of our healthcare system can result in benefits in another. It can also mean unintended consequences. We cannot solve our problems in isolation. A whole-system approach looks at the needs of providers and patients, increasing access to care and how patients interact with the healthcare system, how we support patients to return to where they call home sooner, freeing up beds and resources in hospitals, how we use existing infrastructure to better support patients and reduce pressure in other areas of our system, and how we recruit and retain the healthcare professionals we need to deliver quality and timely care now and into the future. This is not an exhaustive list, nor is it an easy feat in a system that literally touches the lives of every Nova Scotian. Today, we will share more about a whole system approach and how it is helping address pressures related to emergency department closures and the need for more healthcare professionals. Things like improved and expanded virtual care for all Nova Scotians, more services at pharmacies, mobile clinics, primary care clinics, after-hour and urgent treatment centres, and Your Health and Us, an app that puts healthcare information, resources, and services in the hands of Nova Scotians. These and other initiatives are meant to help Nova Scotians see the right provider for the right care at the right time. When that happens, it also keeps patients out of emergency departments when they don't need to be there. Delivering more, faster care also means recruiting and retaining skilled healthcare professionals that are in high demand across the country. In particular, we are here today to discuss physician retention. Through a new and competitive contract with physicians, the Community Fund grants, a new medical campus in Cape Breton, and the Patient Access to Care Act, we have many initiatives that will keep medical graduates working here and support others to make Nova Scotia their home. We look forward to taking your questions. Thank you.
Thank you. And just Ledge TV had mentioned Deputy Minister Lagacé, and I'm going to guess possibly also Ms. Oldfield. If you can make sure that mic is pointed towards you. It's just yours was off to the bit. So would you be next, Ms. Oldfield, or Doctor, who's next? Ms. Oldfield, thank you.
Thank you. Just very briefly, Mr. Chair, I would like to echo what the deputy has said and just fully praise our emergency department care teams, but really all of our frontline healthcare workers across the province. I had the privilege of doing a tour of many of the facilities in the Western Zone 3 weeks ago and had the opportunity to speak to many of our frontline employees face to face and to hear their challenges and to try to walk for a few minutes in their shoes. And they are unrelenting in their work towards excellence and to providing care for Nova Scotians. So I look forward to the opportunity to share and learn today, and thank you for having us.
Thank you. Dr. Colin O'Dane.
Good afternoon. Thank you for giving me the opportunity to speak to you today. I'm just going to apologize in advance for my voice. I've had a little bit of laryngitis, so if it gives out, forgive me. As I said before, I'm Dr. Colin O'Dane. I'm the president of Doctors Nova Scotia. I'm also a staff anesthesiologist based in Halifax. I'm not an emergency room physician, but I have a significant level of respect for the work that they do and the work of all healthcare providers working in emergency department and urgent healthcare centers throughout the province. It's important that we begin today's discussion acknowledging that physicians' stress and burnout are at an all-time high, while physician wellness is at an all-time low. In particular, while the topic of discussion today is emergency department closures, I think it's important to acknowledge that emergency department closures are really a canary in the coal mine. They tell the tale of a healthcare system that is under significant strain. I recently met with emergency medicine physicians in the community across the province, such as Digby, Cape Breton, Truro, and HRM. Each community is facing different pressures and challenges. The solutions to their problems need to be tailored to their unique needs of those communities. However, there was a common thread: shortage of physicians and other providers who are necessary to keep emergency departments open. In most cases in rural Nova Scotia, family doctors take shifts in the emergency department over and above their office practice and other work in the community. Family physician shortages mean there are fewer doctors to cover rural emergency departments 24 hours a day, 7 days a week. There is also a national shortage of emergency medicine physicians, so the recruitment landscape is challenging. Physicians and nursing shortages are the primary reason emergency departments close. This means our province needs to be creative in how we address the challenges in the emergency and urgent care and seek ideas from those who are on the front lines and have a depth of knowledge about the communities that they serve. So I encourage all the partners in the healthcare to continue engaging healthcare providers on the ground and listen to their ideas and ask more questions. In addition to some of the solutions to the emergency room closures, they lie outside the emergency department. All partners in the healthcare system need to be working together to find creative and integrative ways to improve access to care, support physician recruitment and retention, promote patient attachment to family doctors, and contribute to creating a healthy and positive work environment for healthcare providers. I'm going to sort of stop short of my initial remarks just to preserve my voice, but most of what I was going to say after that had to do with the new contract, and just to say that I think that we've been making significant strides in achieving some of these goals, and I'm happy to take any questions about that.
Thank you, Dr. O'Gowan. Okay, so just to remind everybody, this committee works off 20-minute, 20-minute, 20 minutes. At the end of 20 minutes, I'll call order, and then we'll go to the next priority. There'll roughly be 10 minutes of the round beginning, and just wait until the mic's on before you start speaking and recognize. Don't feel bad, we do it too. And I will start with the Liberal Party with MLA Regan.
Thank you, Mr. Chair, and thank you to everyone for coming in today. So if we look at the annual accountability report, if we look at the unplanned closures between April 1st, 2021 and March 31st, 2022, I think it says that unplanned closures were for 31,697 hours, or 1,320 days during that period, and that's up. That's double from the year before, which was 627 days. And then this goes and puts further strain on other open ERs like Cape Breton Regional Hospital or the hospital in Kentville. Do we have the number of unplanned closures over the last year thus far?
And that would be directed to?
I think to Deputy Lagasse.
Deputy Lagasse.
Yeah, I don't have that number for this past year. The annual accountability report is filed by the end of December, so it's just being finalized now and will be filed by the end of December.
MLA Regan.
Thank you. Otherwise, I would have asked for those numbers, but since they're coming in a couple of weeks, that's great. If we look over at the Annapolis Valley, where they've faced significant pressures over the last couple of years, first Annapolis Royal, the hospital there was closed, and now Middleton Soldiers Memorial Hospital is rarely open, the ER. Our colleague from Annapolis has been advocating and asking the minister and the department when or ever is the ER going to be fully staffed and reopened. So we've heard that NSH executives in the Western Zone have committed to getting Soldiers Memorial ER back to 24/7. So I'm asking, I guess, Ms. Oldfield, when will the ER be fully reopened in Middleton? And when will it be, or is it going to be permanently shut down?
Ms. Oldfield.
Thank you. There is no intention to permanently shut down the emergency at Soldiers. In fact, that is one of the places I visited just 3 weeks ago, and I can assure you that there is every intention to recruit and to augment the hours. In fact, they were recently increased a little bit from the hours that we had seen over the course of the last few months. And the folks on the ground are working hard to recruit and to find the ways to make sure that the emergency department is open more. So there's no intent to close, every intent to find the ways to augment what we have. Absolutely. A very important part of our province.
MLA Regan.
So I take from that we don't have a date when this will reopen, and do we have a date for when we will see significant improvements in the hours it will be open?
Ms. Oldfield.
We do have a date where a new physician is joining and will be spending time between Valley Regional and Soldiers. So that will be in January, and I think that will be a big help.
MLA Regan.
Okay, so another ER department that we have seen significant impact on the area is in Badek. We were recently, some of my colleagues were recently in the area, and they heard a lot about when they were talking to community and healthcare workers, and many of them told that our folks that the ER being closed has had significant impact on the safety and health of the community members, but also those who actually come and visit the Cabot Trail, drive from Badek to actually get to Sydney in an emergency situation. Now, in April, the department said it wouldn't be reopening the ER anytime soon. So my question is to the department, I guess, do you have an updated answer as to when the ER in Badek will be reopened?
I'm just looking. Oh, Ms. Oldfield.
I'll start and ask my colleague to join in as well. The very complicated emergency department in Badek, and again, very important to the entire island. And another place that I visited just about 6 weeks ago, in fact, so I had the opportunity, I spent 2 hours there with the foundation and with, again, team on the ground and some other community members. So another place where they're very anxious to love to get back to an ER. We have urgent treatment there, and hoping and working to a model, again, that is sustainable, that can persevere. One of the challenges, and I'm not saying it's right or wrong, I'm simply saying it is a challenge which is expressed broadly in the community and certainly with our healthcare providers, is when, one of the challenges with Badek is that when it was operating, many people were coming from, quote, over the mountain, as they say, but coming from Sydney and other areas, with the consequence of overwhelming the ER and the physicians there at the time, a couple of whom were very new to the area, new to the practice. So that we need to find a way that we can equalize through the regional and other areas so that they can have a slice without being overwhelmed. So that's part of the challenge. So that's something that we have to grapple with and find the answer to. And as I say, I'm not saying it's right or wrong. I'm saying it's one of the challenges that we have to grapple with. So
just a second, I'll double check. MLA Regan? You're good? Okay. MLA Regan.
Thank you. So I take from that we don't have an updated answer as to when the ER in Badek will be reopened, and while we're at it, the reopening or the extended hours in January that we just heard about for Middleton. Do we know how many more hours those would be?
Dr. Boulier.
Thank you for the question. I can't speak to exactly how many hours because that it will depend on one of the beauties of the emergency system all working together, and that we haven't highlighted yet, that our 10 regional centers as well as our tertiary center never close, and we're quite unique in the country about that we have not had a closure in those type of facilities. So often we draw resources from outside in to make sure that we keep that system stable. As we do that, it does depend on month to month what the hours would be, but it will be a big help. And the example in Middleton will show you some of the benefits of the contract that Dr. O'Dane had mentioned, was that we have developed a way of having kind of a hub and spoke model for the physician where they can be committed fully to a site but have a bonus to be able to support a community site as well. So as we hire more people and they come into that new system, we're hoping that's going to beef up the support to those level 3 emergency rooms. With Badek, Dr. Don Bryan and Brett McDougall, the executive team in the Eastern Zone, are working really closely with that community about what the community wants and needs and how they can work with the doctors that are there now to provide a stable service. They're an urgent treatment center now, so they are open regularly for urgent treatment, and they are piloting a few things with EHS in the area to kind of expand that service for the locals. The goal is still to try to have a level 4 emergency room there over time, and with the right support, I think they'll get there.
MLA Regan.
So I take from that we don't have a date for that particular one, and we don't really know how many more additional hours we're going to get in Middleton. So thank you for confirming that. I'm going to switch over to doctor recruitment. I had a reach out yesterday from a young person who lives here in Metro, and they shared with me the letter that they just received from their family doctor who they've been with for the past few months. This person has been on the wait list 3 times now in the last 3 years. Every time they get a doctor, the doctor leaves. The latest one says, "I'm writing to inform you that after 1 year I am closing my family practice of medicine." And that'll be in February of next year. So we keep hearing about doctors being recruited. How long are doctors staying? Are they actually staying for permanently, or do we have any idea how many are leaving after 1 year, and why are they leaving after 1 year? And I'll just table that with the clerk so she has a copy of that.
Okay. So Dr. Bootler.
So we know over the last 2 years that we've had a net gain of 150 physicians into Nova Scotia. With, I don't know the details of that, so it's hard for me to speak to that example, but in general, sometimes doctors do switch their focus of practice, in particular in family medicine, as there's a lot of opportunities for emergency work, hospitalist medicine, specialist care. So I don't know the specifics of that. We did last year put in a physician hotline where if people are struggling with their family practice, they can call us or any practice. And we send out a team that's composed of people from the Office of Healthcare Recruitment, as well as Nova Scotia Health Medical Affairs, as well as the Department of Health and Wellness, to actually go to the practices and meet with them. And I believe MLA Barkhouse was at one of those, the ones that we did where, we invite community members in and see what we can do to help with the practice. So we'd be happy to take that example and have a look and see what we know. We do know that a lot of our physicians stay when they come. We had a 90% retention rate, and when the 10% that have left, we do exit interviews on people that aren't retirees, and the majority of reasons that they're leaving are for family reasons. They have family in other parts of the country, or the other reason they sometimes leave is to get more training and to do specialized work that they may or may not bring back to Nova Scotia.
MLA Regan.
Thank you for that, and perhaps you could speak to what a person like that who has a health condition that they're trying to have investigated, how are they going to get their tests? Where should that information be deposited now that they no longer, once again, do not have a family doctor?
Sure.
Dr. Bootler?
Sorry.
No worries, we do it, trust me.
We worked really hard to increase primary health care access for people that are on the list or not getting regular care. This year alone, we've had a total of almost 2 million extra visits. We're up 18% from last year. We have community pharmacies, we have pharmacy pluses, we have virtual care in Nova Scotia. We have access for people that are on and off the list for that. Mobile clinics, primary health care clinics, there's UCCs, UTCs, urgent treatment centers. So we've created a lot of primary care access in the community for people that need it, such as your example.
MLA Regan.
So you have a problem, so you go and you have tests done. Where do the tests go? Because that's the concern that I'm hearing from people. Yeah, I can go, if I have a sore throat or something like that, but there's no place to, if it's somebody with a complicated health issue, there's no place to send those tests to. If there is a place, people are not aware of it, so that's why I'm asking.
Dr. Bootler.
Yes, there's 2 places. Unattached people through Virtual Care Nova Scotia have the ability to have regular follow-up with the person that they see on that in that system for tests. The second piece for unattached patients are primary care clinics. We have 14 and expanding to 19 across the province, where people that are on the list can make appointments and be referred to a PCC, and they would be seen in person. So if you go on Virtual Care Nova Scotia and you end up needing to see somebody in person, you'd be referred to the PCC where they would see you in person. You probably have heard we have developed an app that allows people to look at the choices for what's going on with them. So we're hoping that will help patients navigate to the right place by answering some simple questions as they go on it.
MLA Regan.
So people are being told that that's not the case when they go in. That they can't see the same person, that there's no place to send the test results to. So I'm not sure that everybody in the healthcare system understands how that particular aspect of it works. So I would just urge that if that is the case, everybody needs to know it, because they don't know that at all. And so that's what we're hearing from people, that they can't, they're being told. So I wanted to share that with you. Recently, I had an exchange back and forth with a health minister. She was very helpful in letting me know how many doctors had been recruited in my particular area. This was before I became health critic, so I was just asking about sort of my neck of the woods. And we went back and forth. But one of the things I think that we're not sort of grappling with is the number of physicians that have changed how they're practicing. So, you know, someone may still be listed as a doctor who's continuing to practice, but in fact has reduced what they're doing or changed what they're doing. And so, you know, when I pressed further, I found out that, you know, in my neck of the woods, we were seeing reductions in service even as we have more and more people moving into the Bedford-Sackville area. So, pardon me? I didn't catch that?
Excuse me?
I didn't hear what you
order.
said.
Order. MLA Regan.
So, I'm wondering if it's possible to get the data on physician retirements and service reductions or changes for the entire province. I recognize that you may not have that information at your fingertips right now, but I would like to know how many physicians are actually leaving, and that's retiring, closing their practice, or changing what they're doing. Because I think that is having a big impact. And certainly when we look at the most recent doctor recruitment numbers, where we see the numbers continuing to rise, it was over 3% in Metro once again this past month. So I would like to see those numbers if possible.
So I would assume that will be, Associate Deputy Minister Beaton.
Yeah,
I would
sure.
assume which one it's going to.
I was wrong, so.
Sure. I think in terms of the overall data, what we can say, and Dr. Bootlier had referenced this earlier, there's been 150 new physicians this year in terms of net gain. No, yeah, sorry, you're correct. It is. It was from September. It was 2021 to 2023. But out of that, what we do know is that there was 312 new starts and there was 163 departures. And those departures could be for a number of reasons. We would have to look at the data to see if we could break it down a bit further than that. The other piece that I would just touch on is that the new contract that we've had, there's significant interest, and I would say that, you know, the early indications, because we've just implemented this effective October 1st, so like sort of new information, but it is showing signs that physicians are making decisions to continue to practice in community rather than closing out practices and providing ongoing support to patients. So we do believe that the new contract is a signal of continued progress in retention.
MLA Regan with both 3 minutes.
Yeah. So if I could get, you know, the number of physicians who have reduced their practices, and I think we would need to see the data as there's a reduction. You know, it's a big difference to have somebody reducing their practice hours by 10% versus somebody who's doing it 50%. So I think it would be really good information for us to actually understand what those reductions are, because they are happening, and we're hearing that from Nova Scotians. So if I could get that provided to the committee, that would be a huge help there. In terms of I'll pass that over to my colleague. Yeah.
MLA DiCostanzo. Did I do it right? Perfect. You have 2 minutes.
Thank you. Thank you again. And my question is actually to Doctors Nova Scotia. Your predecessor said that the situation at the ERs is not surprising, and things have just gotten worse. We know that in the number of primary care doctors. So people were going, you know, to emergency for primary care services. So what are you hearing from ER doctors, and what support do they need from the government, and how does closure impact already is impacting on already burnt out and overburdened healthcare workers? You know, what is the situation? What are you hearing?
Dr. O'Dane with about a minute.
Well, I think it is having an impact, and what I've heard from emergency physicians that they're really struggling to try and keep the emergency departments open. I believe that having more family physicians will improve the situation, not only because they're going to spend time working in the emergency departments, but because providing access to patients will keep many of those patients away from the emergency departments. And I'm hopeful that the new contract, specifically the longitudinal family medicine model, will help improve provide incentive for people to spend more time providing that type of care as opposed to go to other areas and aspects of medicine which will help alleviate the problem.
Thank you. You got like 10 seconds.
I will come back to you in the second round.
Okay.
Done.
So, MLA LeBlanc.
Thank you very much, Mr. Chair. So I'll start with ER closures and delays. So, you know, it's difficult to grasp the depth of the problem or assess the success of different initiatives without up-to-date information and data from the emergency department. So unfortunately, the most recently released data on physician vacancies, physician hiring, and ER closures is well over a year old. So I'm wondering if someone can provide up-to-date numbers for these different categories for the past month. How many physician vacancies are there currently in emergency departments, and how many emergency physicians have been hired, i.e. net increase for the last month?
And MLA LeBlanc, you said 81, so I'm just going to look to see if
I don't know who's
if they're
best
going to
to
have
answer.
it or whether they're going to have to get it to us. So, Deputy Minister, Deputy Minister Lagacé.
Yeah, no, I'm sorry, we don't have that information with us.
They did the wrong mic. There you go, Deputy Lagacé.
Thank you, Mr. Chair. We do not have that information with us today for the last month.
And can you get it to us?
Yes, I think we can, I don't know, Nicole, I don't want to commit to that one.
The clerk will send a letter out asking for some stuff that wasn't there.
Perfect.
So it's I know the clerk's doing a great job of that. So you have a comment, Ms. Oldfield? Your hand's up, Ms. Oldfield?
Yes, just to acknowledge that we can break it out, and we'll take just a number of days to produce that. So yes, we have it, and yes, we can get that. Not a problem.
Thank you very much. MLA LeBlanc.
Great, thank you. And then the other number I was wondering about is how many physicians have been hired through the Come Home to Nova Scotia program, or campaign, I guess, in the last month.
Ms. Oldfield?
We would not have the last month, but again, we can make the numbers available. We just need to slice and dice a little bit. We just don't have them here.
Yeah, okay. MLA LeBlanc, they'll be coming.
Great, I appreciate you getting the numbers to us. It's unfortunate that we don't have them today, because then we can't look at them as a committee, but perhaps we can have a follow-up meeting if necessary, Mr. Chair. There were more deaths in emergency departments in the first 9 months of this past year, this year, 2023, than all of last year or any of the 5 years before that. So we know that the challenges in the system, like the growing number of Nova Scotians without a family doctor or emergency closures or wait times, are all interconnected. So I just want to ask about how those issues lead to worsened patient outcomes. So earlier this fall, the Premier dismissed the increase in ER fatalities as being, quote unquote, the nature of emergency rooms, because he was like, well, people go to the emergency room when they're really sick, and so more people die there. But I'm just wondering, I guess I'd like to ask Dr. O'Dane this, as you were speaking about the stress on emergency room physicians and healthcare workers in general. So do you agree with the Premier's statements, like that it's the very nature of emergency rooms, or do you believe that there's more to be done to reverse the trend of more fatalities and improve health outcomes?
Dr. O'Dane.
Well, I think it's hard to show that there's a cause and effect. Obviously, it's concerning if there's a trend towards more fatalities in the emergency department, but without knowing the details of those fatalities, it's really challenging to make a comment with regard to that. It is true that when people are in a dire situation, they go to the emergency department. Sorry, could you repeat the rest of the first part of your question?
MLA LeBlanc.
Well, just that, we know that like wait times and deaths are related to, lack of primary care, that kind of thing. So, in general, are we seeing trend? Well, we know we're seeing a trend, but are we seeing a connected trend? And also, I guess, if there's no way to make those connections for sure without knowing the details of the fatalities, then is there any work done internally on those, like when someone dies in an emergency room? I know there's there's an investigation done, but like, can we, obviously without knowing personal information, but can we say, okay, this many people died from chronic disease, related issues or whatever?
And that question is to?
To Dr. O'Dane.
Dr. O'Dane.
Sure. So I think, so typically whenever there's, what we call morbidity or mortality, so, someone dies in the hospital, or there's an event that is challenging, most departments have quality assurance to look at each individual situation to try and determine whether or not there was something that could be changed in the future to decrease the likelihood of that event happening. Don't always find that there's something that can be improved upon, but that's the purpose of that type of investigation with it, and I assume that that's what each emergency department has. I know that's what my department has, and we look into all those types of situations. With regard to your question about wait times in the emergency department, and that's, I guess what I would say is that emergency departments would triage the most acute patients, and they would not be the ones waiting. They would be the ones that would be seen right off the bat. That's not to say that not having resources is a problem. If they're struggling to get through patients, that's going to be a challenge, and it's going to cause a moral distress for the people that are working in the emergency departments. So having more resources will, I think, overall improve the environment, and the care will be better for everybody. But I don't think you can make the connection between the increase in fatalities with the human resource issue that we have.
Emily LeBlanc.
Okay, thank you. I saw that there was some discussion over here, but if either of you would like to make a quick comment on that.
Oh, thank you. Dr. Boutlier.
Thank you for the opportunity to answer.
There it is, Dr. Boutlier.
Thanks for the opportunity to answer. We do know one thing is that the CTAS levels are increasing. The acuity of patients presenting at Emerge is going up. Like if you look over the same 2-year period, we went from like about 20% to about 30% of people being in a category of 1 or 2 of the urgents. So, and we hear this all the time, whether it's folks going to the OR or folks coming to Emerge. The acuity that the doctors are experiencing is much higher than they've ever experienced. It has a lot to do with, COVID and, breaks in, people, doing things later than they would have in the past. And, we continue, and also just the frailty, the general frailty and age of our population has made the presentations that much more acute and Emerge. So some of the focuses that we've had are on actually identifying, we're actually call it frailty at the front door, and trying to really assess people as they come through the door for all those things that we know that makes their care so much more complex.
Emily LeBlanc.
Well, that's really helpful, and I wonder if there is any data that could be looked at in terms of connecting those high acuity, the people presenting with high acuity. Is it connected to the fact that they don't have regular family care or primary care? Is it connected to the income situation where we know that people are cutting their prescriptions in half so that they can spread them out over longer time? Like, do we have any concrete data on all of that? Because I would suggest that, like, for sure in the city that stuff's happening all the time. Yeah.
To Dr. Boutlier.
Yeah.
Dr. Boutlier.
Yeah, so that's very, that's something that we do across, like Dr. Dane was explaining, like morbidity, mortality, we like quality reviews, that type of thing. So we do look at, cases like that. And we could, if we do see trends like across cases, we watch for that too. Like if there's something that's system-wide impacting on what we're doing. But, that would be like sort of under the quality review process that we would get that type of detail.
MLA LeBlanc.
Thanks. I just wanted to ask a question about urgent treatment centers because we've talked about it, or it's been talked about so far in the committee meeting. Earlier this year, a Cape Breton emergency physician told reporters that urgent treatment centers are absolutely not comparable to an ED, and some of those places should have been some of those places that have been turned into urgent treatment centers should be turned back into emergency departments immediately. So my question is, can you speak to the difference in care available between urgent treatment centers and collaborative emergency centers or emergency departments? For instance, and I'd like to know more than this, but can an ambulance go to an urgent treatment center? And I guess I will ask that to Ms. Oldfield.
Ms. Oldfield.
I'm going to defer to Dr. Butler.
Dr. Butler.
Thank you.
Sure. So an emergency room is definitely not an urgent treatment center. They're very different in that an emergency room, it's for the highest level of illness, like the triage 1s and 2s and 3s. And, it's providing a different level of care. They're open 24/7, various things. They would be on the EHS status system where they would go there regularly. Urgent treatment centers, on the other hand, are for more urgent type care that people can't necessarily wait for an appointment for, but they have regular appointments available every 24 hours, like so that it's same day, next day access to it. And they would see things like if you needed stitches, perhaps an x-ray, depending on the place in the province where you are. There's some variation. They're all based on a standard set of things that they do, but there is some variation per site to site depending on what's available at that site. So they definitely have a different scope of practice, but it is something that's very widely used by people. They can get those appointments. Now, and you mentioned the ambulances coming to UTCs. You mentioned ambulances coming. So we have been trialing, working with the EHS, looking at what we could potentially take to a UTC during the day, and we're piloting a few things around that.
MLA LeBlanc.
Great. Well, thank you for explaining the differences. I mean, I will nitpick a little bit and say that, the fact is emergency departments aren't open 24/7 because that's why we're talking about these things. There's many that are closed for, days at a time or just open for limited hours. And I think this is what the doctor is getting at, that like in certain communities where emergency departments have closed and what's replaced them, or, for lack of a better word, is a UTC, it doesn't make much sense. Also, I have a question about the UTC really quickly. Is it not true that if you go to a UTC, you must already be connected, you must already be attached to a family practice somewhere in your community? No. Okay.
Dr. Butler.
That's great.
Okay.
So
no.
can I?
Do you want her to?
No, that's okay. Well, no, I think my colleague wants to ask.
You've got 8 minutes, just so you know.
Okay. Okay, sorry, go ahead.
Okay, Dr. Butler.
I just wanted to make the point the emergency system is never closed 24/7. Like we have regional centers, and we ensure that, like when we're doing with EHS, we work very closely to make sure that people get to the right center for the level of care they need.
MLA LeBlanc. Or are we going to MLA Burrow?
Just sticking with this. So this was, as I'm sure you're aware, Dr. Margaret Fraser, who made this point in Industrial Cape Breton. And so she's, as I understand it, she's saying that the range of services that an emergency department provided is the range of services that is in fact needed in some of the communities that she and the physicians she speaks for are serving, and that range of services needs to be reinstated. I think that's her point, given the on-the-ground clinical experience. So does she not have a point? Is she missing the markers, or something that she has overlooked?
So,
Dr. Butler.
So the executive team, leadership team, and the primary healthcare team and the emergency team at the North Side and Glaze Bay, they would all have worked together to come up with a solution for that community that they felt that they could meet the needs of. And many of them, have come back to this type of care after not doing it. Like North Sydney had been closed for a number of years prior to this. So, we can provide the service that everyone needs. I want to make that point. Regardless of what they have, they can get that service. The urgent treatment centers are a different level of care. We do have a lot of emergency rooms in Nova Scotia for the population, and we are working every angle we can to keep what the community tells us that they need. A lot of these are born from community meetings and engagement with the communities, and we work with the communities to provide service, and they like it. They come to depend on it. It's regular, it's scheduled, they can get it, they know when it's open, and that has been a big improvement for a lot of these communities.
MLA Burrow with just over 5 minutes left.
Can I take it back?
Oh, I guess MLA LeBlanc with just over 5 minutes left.
Thank you. In January of 2023, as part of the actions to improve emergency care, the department committed to hiring physician assistants to provide care in emergency departments. So I'm just wondering if maybe Deputy Lagasse could confirm how many physician assistants are currently working in emergency departments and at which locations, and what plans are there to expand the physician assistant in emergency departments program?
I'm expecting that'll be either Deputy Minister or ADM. Deputy Minister Lagasse.
Thank you. And I'll ask Dr. Boutler to jump in if I don't have this exact right, but currently there are physician assistants in 4 sites: Dartmouth General, Cape Breton Regional, Cumberland Regional, and South Shore Regional.
And the B part was what plans?
Emily LeBlanc.
My B part was what plans are there to expand so that there are more sites with physician assistants in emergency departments?
Deputy Minister Lagasse.
Thank you, Mr. Chair. So we're always working with our partners at NS Health to be able to expand the program. I think you'll know that earlier in the year, we did announce that at Dalhousie University, there's a physician assistant program starting in January with, I think it's 24 students. And so we're starting to train them here ourselves, always looking where they may want to come from other places, but absolutely actively looking to expand the program.
Emily LeBlanc.
How much time?
3 minutes, 30 seconds.
Great. I just want to ask a quick question about family practice anesthesiologists. That's the right word. So, I understand that in some places there was a pilot, or maybe in Yarmouth, was it, that there was a pilot for a family practice anesthesiologist? It makes sense. It seems like it's, well, I don't know. I want to know what you think. And if the pilot is going to, or the idea is going to expand, are we going to start training family practice anesthesiologists here? I understand that there are some family practice doctors who would like to, improve their skills, but so that they can stay in their communities and practice in Nova Scotia. So could someone just speak to where we are with that?
I'm guessing Dr. Boutler, you're looking at me?
I could, yes. Okay. Thank you. Yes, we have run recently a family practice anesthesia pilot. We had a lot of learnings around that pilot, and it's currently being evaluated for spread and scale across the province.
Emily LeBlanc. With about 2.5 minutes. MLA Burrow with about 2.5 minutes.
Well, thanks. I'd like to go back to this question, Dr. Boutler, about the urgent treatment centers. So you've said that they are popular. I don't think there's any question about that, and I think you're right too. That in light of some of the mega closures that they are an alternative to, they're particularly welcome. But I don't think this is Dr. Fraser's point. Dr. Fraser's point is that that in some of the areas where the physician community is serving in Industrial Cape Breton, the clinical need is for what is provided at an ED more than what is provided at an urgent treatment center. So the question I'm interested in your analysis of is she not right?
That's to Dr. Boutler, correct, Emily?
Yes, please. Yeah.
Dr. Boutler.
So we could have, a debate about how many emergency rooms is the right number for Nova Scotia. We could have a debate about what providers are doing what and what's in what area. What I want to reiterate is the regional hospitals that are never closed, that are open 24/7, provide all the services Nova Scotians need. And we are connected through an emergency health system that everybody, is working together to take the folks to the right place at the right time. So it is a change. There's no doubt it is a change. But we're talking about emergency rooms that were closed in the current status because you could not get people to work in them. And so they were going to where they're going now anyways, but now we have backed it up so that people don't have to go for everything. They can get service in their own community for a variety of things now that they couldn't before. And to me, that's an improvement from where we were.
Emily Burrow with 25 seconds.
Would you not acknowledge that Dr. Fraser knows something about this and that she may have some point?
Dr. Boutlier.
Dr. Fraser is an emergency room physician that worked for a long time in Cape Breton. So, she is a member of that emergency room community. So they all have had, an opportunity to provide services and contribute to,
Order.
what the current.
That's the end of the 20 minutes. Next will be MLA Barkhouse.
Thank you, Chair. This question is to Deputy Minister Lagacé and CEO Karen Oldfield. As leaders in the health system, I am sure you are concerned about emergency department closures and are committed to finding ways to reduce closures and adjust services. Can you tell us what can be done to help reduce closures, and are there indications that investments underway across the health system can or have been or will lead to fewer closures?
Oh, Deputy Minister Lagacé. There you go. Deputy Minister Lagacé.
Thank you, Mr. Chair. Thank you for the question. I think I'd start by speaking about the Emergency Department Improvement Plan that we released in January of last year. And we spoke a bit about it when we had the question about physician assistants. A number of things were announced in that plan that we've been able to move on, including adding physician assistants in 4 sites and nurse practitioners to 8 different sites. So there are different practitioners have been added to care teams. We've added care providers and patient advocates in a number of patient advocates in 11 sites and care providers in 5 sites. And we've also added virtual emergency care at various locations, 8 sites, so that people can, with less urgent needs, can be seen through virtual care as an option in that emergency room. The flow lead and offload assessment teams have been added in 8 sites, and we've established the Care Coordination Center in at the QE2 as a first location, but it is being expanded across the province. So a number of initiatives taken in the emergency rooms in particular, and perhaps my colleague would like to speak about things we've done in relation to primary care to help people to avoid having to attend at the emergency room.
Ms. Oldfield.
Yes, thank you. Diverting from the emergency department in the first instance where appropriate is one of the things that we're focused on as well. And we talked a little bit already today about creating a number of additional primary care access points. And actually, if you were to add it all up between the community pharmacies, our Pharmacy Plus, the virtual, the mobile clinics, and the whole gamut, it is pushing 60,000 additional appointments a month. So that's a lot of appointments. And the corollary is that where appropriate, people are able to access and hopefully, depending on their particular situation, not end up in the emergency department. Now, this is really preliminary. Okay, so I'm going to be very interested in the full year numbers. Dr. Boutlier spoke earlier about the higher acuity, so a higher percentage of CTAS 1 and 2 coming into the emergency departments. The reverse of that is we're actually seeing slightly less 4s and 5s, which what we're trying to prove out is that because there are increased access points that they're able to seek care there. So preliminary information would suggest that our strategy of diverting from the emergency room is starting to work. So very preliminary. I'm not drawing any scientific conclusions at this point. The other thing that's I'd like to speak to, and that helps that, Dr. Boutlier alluded to Your Health Nova Scotia. Your Health Nova Scotia launched on November 1. We've had 135,000, just over 135,000 downloads since that time, and the evaluation so far is very interesting. But what it's showing us is that there's a high conversion rate of people who are able to navigate. So that is one of the objectives of the app, helping to navigate, showing all the different pathways to care. The virtual aspect is very novel, and any unattached person can seek virtual care through that app. And I think in a month we've had close to 13,000 virtual care visits from unattached people. And there's also an aspect for attached people to use the app, and for free twice a year. And I think the number there is maybe just under 800. So that's going to help. It is helping and going to help. And the fact that, you know, we've had that many downloads in a relatively short period of time, I think it is one of the things that is going to be a pathway to the future. So it's very important and will help and is helping to divert away from the ED. So the diversion theory strategy is very important to our fragile ERs across the province.
Emily Barkos.
Can you update the committee on the new Your Health NH mobile app and how you intend for it to address some of our broader healthcare needs?
Ms. Solfield?
Sure. Well, I just sort of started down that path, but I'll just, I guess, throw in a couple of more things. If anybody has not downloaded it, you can access it on your phone or a web version. I would encourage you to play around with it. So there's one of the things that is important and which we will be able to use to really help Nova Scotians is there's a significant education component. So, you know, for those who have a chronic disease, I'll just choose diabetes, there's a lot of material that one could refer to if they have a recent diagnosis or want to learn more about that particular thing or have a family member or friend. So that the education parts are very important as well. And, you know, this is version 1. Version 2, I think, is scheduled to come out early in the new year. But one of the things that people like is the ability to start to control, to have more agency over their own personal health. So it's in the palm of their hand, it's on their computer. So you can't do everything we intend it to do yet, but you can make a blood collection appointment, you can make appointments for vaccines, you can make x-ray appointments, and you know, eventually you will have more things in the palm of your hand, like the results from those tests. So as I say, it is going to be a very important piece of our healthcare, not just in Nova Scotia, but across the board, so that people are able to direct and guide and navigate and educate themselves. So not just the health part, but the wellness part, which I think ultimately is something that we need to be talking about a lot more in Nova Scotia.
Emily Barkos.
I agree 100%. I love it. It was just the other day that I downloaded it with a constituent, and the fact that they now feel that they have some control as well is fantastic. So you guys are so great that I had 6 questions. You answered them all. And those 2 little things. So what I will do is pass it on to Nolan and work on some more.
MLA Young.
Thank you, Mr. Chair. I just wanted to say, you know, Shelburne was one of the first places to be able to have the pharmacy pilot, and it's a piece of the puzzle. It's taken some strain off. You know, there's always more things to do, but we're off to we're moving along well. My question would be to ADM Beaton and Dr. O'Dane. I understand the new four-year physician and clinical. I understand the new four-year physician and clinical academic funding agreement with Doctors Nova Scotia contain a few measures focused on emergency departments, such as hourly rates and the framework for a service agreement for emergency physicians. And I'm just wondering if you could talk about these measures and any other measures in the agreement that would be aimed at improving the ED situation.
Okay, we'll start with ADM Beaton.
Yeah, thanks for the question. I'm happy to start and then can pass it over to Dr. O'Dane for some additional comments. But I think the biggest piece was that, you know, emergency departments will see emergency department physicians will see a 10% increase in their wages or contract over the life of the contract. In addition to that, there's also what we call the Rural Specialist Incentive Program, which provides an additional $16,000 for those that are working in rural emergency departments. That also, which is particularly important because many of them also have family practices as well in their community. There's a rural EDs are often staffed by family physicians, so that's why that particular component is really important. The increase, there's an increased rate hourly for physicians and EDs. There's also increase for the broader department funding as well, for the rates to make it more competitive, particularly in tertiary hospitals, but also there was a $10 increase in regional hospitals, as well as an increase in community-based hospitals to make them more competitive. In addition to the community hospitals, there's also been an increase in the hourly rate, as well as a potential blend for we created an hourly rate specific for community-based hospitals to make them more competitive. There's also enhancements to what we call our locum program to allow physicians that are not necessarily from those communities to travel. So emergency physicians now have the availability through the locum program, including those that live in the central zone. And in addition to that, we have, as part of the contract, the 2023 physician contract, we've also instituted a review of what's called the Murray Hybrid Formula, which is the formula for funding for emergency departments. It's expected to be completed in June of 2024.
Dr. O'Dane.
I think Craig touched on most of the things that are in the contract, but I would like to highlight the Murray Hybrid Formula piece a little bit more. Basically, in its current form, it looks at the volume and the acuity of patients that are in an emergency department over a period of time, and uses that to provide funding to the leadership in the emergency departments so that they can staff their departments, have the funding to do that. A new piece that's been added to that now is to look at, that was never part of the original formula, is to look at patients who have left the emergency department. The emergency physicians that I've talked to feel that that's an important piece to consider, because those, if you had more staff in the department, it's likely or hopeful that you'd be able to see more of those patients, and they may not have left. So I think that's a really important piece to consider, a formula that is a bit more nuanced and flexible.
MLA Young.
Yeah, thank you, Mr. Chair. Dr. O'Dane, you stated in an article that during my term, I hope to see primary care stabilized in the province. Although it's not the only problem we have in healthcare, in my opinion, it's the most pressing today. We are starting to better understand the need for a system-wide approach, the impacts of one part of the system on others. Could you please talk about the connection between stabilizing primary care and stabilizing emergency departments?
Dr. O'Dane.
Right, so I think that I talked about that a little bit before, but as I said in my opening remarks, in a lot of rural Nova Scotia, it's family physicians that are staffing emergency departments. So if you don't have family physicians in the province, you're going to have continued emergency department closures. And the other piece to that is that emergency departments are the overflow for people who don't have regular primary care. So there's a lot of ways to try and mitigate that. But if you have more family physicians and you can stabilize primary care in the province, then you're going to have more attached patients, and you're going to have fewer patients that are going to the emergency department just because they don't have a family physician who could support them. So the work that's been done in the new contract to try and incentivize primary care, I am hopeful will start improving the situation. Anecdotally, the feedback I've had from most family doctors that I encounter is that they're optimistic about this this new model. It's a complicated model. It has a lot of detail in it, but I think it needs to be because the system is complicated. So we're just still sorting through the best way to deliver that, but I think it's going to be a positive in the long run.
MLA Young, and if you could table that thing you commented on. MLA Young.
Yeah, thank you. Sorry.
MLA Young, you're not in the chair, boss.
Yeah.
Keep your hands off that. You know better. He's messing with
Okay,
you.
sorry. My question goes out to ADM Beaton and Dr. Boutlier. The Community Fund from the Office of Healthcare Professional Recruitment, so OHPR, is a great way to support communities in their efforts to recruit healthcare professionals. Could you please talk about some of the projects the fund has supported? And I guess additionally, could you please talk in more general terms about how the NSH and the OPR work with communities and hospitals to address their health professional needs?
Who do you want to start with, MLA Young and
whoever's ready? ADM Beaton.
ADM Beaton.
Sure, I can start. Thanks for the question. So the community fund actually is a really excellent way of getting communities involved in the recruitment process. We do know that when communities are involved, there is a significant increase in the recruitment effort and the success of the recruitment effort, but also on the retention side. It's a very personal decision for people to make to move to a new community, and the community fund actually has been able to really support a number of communities in enhancing that, or their ability to kind of come together as a community to push that forward. Last year there was 28 organizations that were funded. This year we're still in the midst of the process. It was just finalized, so we'll have some the teams going through, but the Office of Healthcare Professional Recruitment is working really closely with communities on a number of innovative and new ideas. There's a few that I could highlight. One in particular is actually one that was out of Pictou County, Dr. Boutlier's home turf, but it's a really great initiative that was done with the community there, where they're actually using 3D technology to bring videos to prospective candidates. In this case, it's physicians. So if you can picture for a moment, a physician is actually given virtual reality. They can actually put that on and see what it looks like to walk into the Aberdeen Hospital, or what the life of a physician is during that day. It's a really powerful tool to sort of give them an idea of what it is that they're walking into. So that's one great example. Truro has done some really unique work with some digital marketing campaigns, again focused on physicians, and they're currently now working through the process of kind of retaining that physician. The fund is not solely focused on physicians. However, it's a fund to actually support all healthcare professionals. And I know you had a secondary portion of that around OPR that I can defer to Dr. Boutlier.
Dr. Boutlier.
About how, sorry, could you repeat that part of the question?
There you go. MLA Young.
Thank you. I can read this again, yeah. I was hoping that you'd be able to the Community Fund for the Office of Healthcare Professionals and Recruitment is a great way to support communities in their efforts to recruit healthcare professionals, and I'm just wondering if you could talk about some of the projects the fund has supported, and additionally, if there's any other general terms such as discussed here, stuff that is working with communities and hospitals to address their professional needs.
Dr. Boutlier.
Thank you. So the thing with communities is these grassroots recruitment communities, committees that have come together in all kinds of, I think we're up to over 40 across the province, are essential for us, because as we recruit a physician or other healthcare professional, they are actually taking the candidate and embracing them by the community and showing them all the things and the people that they can get. For instance, I do come from Pictou County, but I can't take any credit for their project, but they have brought people together in a new way through that committee. Like, I was at a medical staff event there last week, and they have a whole range of folks. We have people that are already retired. We have people that are just new to the town, and like what a difference it makes for those for people to be actually involved in the community. They've had things like they've done learnings around some international. For international folks coming in, like what kind of food that they should have in their grocery stores, what kind of religion access should they have, and that is what embeds people in communities, and that's what keeps people here and helps us retain them when the community puts their arms around our new recruits.
MLA Young with 90 seconds.
I'll be quick. ADM Beaton, the Patient Access to Care Act provided the tools to streamline health professional mobility and make it easier to recruit both domestically and internationally. Could you please talk about the impact these changes have had or could have on recruiting much-needed nurses and physicians?
ADM Beaton.
Yeah, sure. The Patient Access to Care Act is actually about reducing barriers for bringing in healthcare workers from all areas, not just nurses and physicians. A recent example I would give you is some of the streamlining. It was announced last week by the College of Pharmacy, where they've opened up streamlined pathways to a number of jurisdictions. I probably won't get them all correct, but I know the UK, the US, Australia, New Zealand, a number of areas. So it really does speed up the process for us actually being able to bring in healthcare professionals. You're probably familiar with the nursing example with the College of Nursing, who also did this, where they've opened up licensure pathways, and they've had over 19,000 applications, which is, will have a significant effect in terms of bringing in internationally educated nurses in terms of the overall workforce as we move forward. The College of Physicians and Surgeons has also done a number of work. So I guess what I can say about this is that the regulators have really stepped up and have embraced PACA, and it's really been an ability to open the door to allow internationally healthcare professionals to come in a much more timely way. In some cases where processes took upwards of 2 years is now down to a matter of weeks.
Order. So we're in the second round. It'll be 10 minutes each. Looks like we did good. So start with MLA Di Costanza.
Thank you. Thank you very much. And I'm back to Dr. O'Dane, if he doesn't mind. Dr. O'Dane, I really want your opinion on the incentive for doctors to stay in Halifax or outside of in the rural area. And they just talked about that, how much. So first, maybe you can tell us what is the incentive that you're giving to family doctors, to specialists, and how has that, in your opinion, has affected the shortage in Halifax? Halifax has, the number of unattached has gone up 5 times in 2 years. And tell me that is not related to the incentive. You can have as many community members trying to attract, but when they know there's 100,000 or 200,000 if they go an hour outside of Halifax, they're not coming to Halifax. How, in your agreement with the government, was that not part of the agreement, and why is Halifax suffering so much more in the shortage? Dr. Boutlier said we have 150 net gain. Do you have numbers of how many of those actually were in Halifax? Especially in the Halifax West area, we had actually, I have an article here actually that says how Houston government threw gas on Halifax doctor shortage, on the fire of Halifax doctor shortage. And the numbers are here, and I will table that. I also have another article here that says more than 20,000 residents of the Bedford-Sackville network were without a doctor. This is an increase of 378% since 2021, since this new government came. What is your opinion on removing the incentive from doctors to stay in Halifax, and how that has affected having family doctors and specialists? If you can give us some numbers, please.
Dr. O'Dane.
So I don't have any numbers for you, but I can say that this new contract, there was a lot of thought put into where the needs were and how to incentivize physicians to work in various places. So to start with the family medicine primary care example specifically, that's not specific to rural Nova Scotia. the incentives that are part of the longitudinal family medicine model apply to all family physicians regardless of where they work. So there's, as far as I can tell, just as much incentive to work in Central Zone as a family doctor as there would be to work outside of the province, other parts of the province, in more rural communities. And what we were trying to achieve is to make it more palatable to work in that longitudinal family medicine where you're looking after a person from the start of their life to the end of their life, which is what we've been missing in primary care for a little while. And it's been so hard for family physicians to keep a practice open. So, and because there's so many other areas of need and other places, that physicians can work, they've tended to been drawn to other hospitalist roles or other types of medicine. So the idea with this new contract for family physicians was to try and provide them with some overhead support and a model that will allow them to appropriately capture all the things that they do in primary care so that they can be remunerated for that and make it viable to keep a practice open. And that applies to all of the primary care physicians across the province. We also know in terms of specialists that there's a problem maintaining specialty service outside of Central Zone. That's not to say that we couldn't use more specialists in Halifax. We're constantly trying to recruit anesthesiologists to my department, but we know it's a much bigger problem outside of Central Zone, and there were some very specific targeted incentives to stabilize rural specialists, so that would include internal medicine, general surgery, ICU. I'm probably missing one or two, but the idea there was to stabilize those areas so that you had consistent coverage for across the province. So there was an intentional incentive outside of Central Zone for that type of medicine.
Emily DiCostanzo.
Confused here is right now if a new doctor coming in or graduating and wants to start in Halifax, is the incentive is exactly the same as starting in Truro or in New Glasgow. Family doctors is what I'm asking for. I understand you've increased the pay if you're taking seniors or if you're taking people with not acute care. Anyway, so I know that there was an incentive that was removed. What is the incentive for family doctors when they're starting a new practice outside of Halifax or in Halifax? Is there a difference, and what is the amount?
Dr. O'Dane.
I am not aware of there being a different incentive to work outside of Central Zone for family doctors right now. So there might be, is there a specific one that you're referring to that I'm not aware of?
Emily DiCostanzo.
Maybe my question.
Well, ADM is thinking he has an answer. So
please.
ADM Beaton, please.
Yeah.
Yeah, thanks. I think what Dr. O'Dane was trying to get at is really the incentives that we have currently right now. While there is an attraction incentive to outside of the Central Zone currently, and that is an incentive for a 5-year return of service. An incentive, it's $125,000 for a physician to set up practice outside of the Central Zone. But I think what Dr. O'Dane was referring to is we went to great lengths to make sure that those that are setting up family practices, really the earning power that they have is designed within the contract. So the contract outlines a number of ways in which physicians will get paid, and that really is they get paid based on the amount of patients they see, on the hours they work, and in terms terms of the billings that they serve, and they're compensated fairly to do that. So, for those that are interested in setting up in Halifax, as an example, where there is a large number of population, their patient rosters are going to be full quite quickly, and that's a component of that. But there's some additional pieces as well in terms of attachment fees that we have for fee-for-service physicians. So it really depends on the model. The contract is quite complicated in terms of the number of ways that people can be paid, but specific answer to your question, currently right now, outside of Central Zone, $125,000 for a return to service of 5 years. However, I will say that we always look at how best to utilize return to service agreements in all areas of physician compensation.
Emily DiCostanzo with a little over 2 minutes.
Perfect. So can you tell me, in your opinion, that 125,000 is not making a difference when we're having these enormous numbers of just in the last 2 years that Halifax is without doctors? The lineups at the walk-in clinics in my riding is incredible. I was always so happy because we had doctors more than anybody else in Halifax. People want to live here. So there is something that's preventing them from settling in Halifax, and it's gone, 5 times or 300%, 600%. How is that possible without doing something to prevent that in the contract?
And
I don't understand.
And that's directed to ADM Beaton?
ADM, yeah.
ADM
Seems to have the answers.
Yeah, thanks. So I would say that the incentive that we currently have is making a difference outside of Central Zone. So just to be clear, I do think that it has in terms of the numbers. But the other factors that you do talk about, I think, and pieces that we look at from the department's perspective and with our partners at NSH is there's been significant population growth in the last 2 years in Halifax. So, we take those factors into consideration. And I would also outline that in terms of the increased access, like as the deputy and the CEO have outlined earlier, a whole system approach, over 60,000 more monthly appointments available for access to primary care. I think those are other pieces as well that go into the consideration when we're talking about. But one of the biggest pieces I would suggest is that population growth has been significant in the last 2 years, and we consistently are reevaluating how we monitor our incentive programs going forward.
Thank you. Emily DiCostanzo.
So, because of the increase in population, we should be ahead of the game in actually giving them bigger incentive because they're coming to Halifax. So why aren't we doing that? If people are moving to Halifax, and we know that the population is more than half of the population of the province, and we don't, we have zero incentive, we give them to come to Halifax where the population is. We have a brand new outpatient center. Oh, I'm so sorry.
Okay, hold on. I'm just making sure because Emily. So, Emily LeBlanc.
Thank you very much. I just wanted to, Ms. Lagasse, just re-ask my question about physician assistants and the plan for expanding the program. So I had asked what the plan was, and the answer was we're training our own. But can you just be more specific? Like, is there an actual plan? Is there a budget line for new physician assistants hires coming up in the next budget? And if so, where are they going to be hired?
Deputy Minister Lagasse.
I can't speak to next year's budget at this point in time, but I think maybe if Dr. Boutlier would be willing to speak a bit about where potentially the sites would be that they would expand to, because that would be with the NSH and not with the department.
Dr. Boutlier.
So we've had the opportunity to have a pilot site in each zone for the physician assistants. So, and they were listed before, but so we had the ability to hire up to 4 in each of those emergency rooms. We also have physician assistants on a budget line for a 20 to add to primary care, and have had proposals in there. Our biggest problem with expanding a new thing like physician assistants is actually getting them here and having them to fill. So we recognized that really early on last year, and had the proposal in for DAL to start the program in January. And the other thing that we are exploring now, similar to how we've done with other professions, is we're looking internationally and planning a trip internationally to recruit physician assistants.
Emily LeBlanc.
Okay, never mind. Yeah, go.
Emily Burrow.
Thanks. I wonder if we could go back to where we started speaking about emergency room closures. I had a question for Ms. Oldfield or Dr. Boudelier. We spoke earlier about the situation in the Valley and Middleton, and you spoke to that. I'm thinking also about the South Shore, where on one day last week there was a closure both in Shelburne and Liverpool, so the drive to an ER would have been over an hour. And I think it's important to register all the time the depth of concern in communities when this is the case. So I want to ask you, do you share that concern that in those kind of circumstances, as pertained, say, last week in Shelburne and Liverpool, that people may not, in fact, get the help they need in time?
Ms. Oldfield?
Two things. First of all, to reiterate yet again what Dr. Boutlier has said about our emergency health system, 24/7 as a system. And then specifically, I talked maybe 18 months ago to Dr. Al Doucette in Liverpool at Queen's, and he shared with me that day, their Queen's and that particular hospital is not used to seeing an emergency closure. The community's not used to it, and he was very passionate and eloquent. And if you know Al, you know that he definitely would be. And so, yes, these things. I speak to people. They tell me the same as they tell you, and so I'm very. I'm always concerned about it, and that's why all of the things that we've talked about here today, there's no magic wand, there's no magic recipe. We are trying everything to recruit in the first instance, and to make sure that our people are treated fairly. So the contracts that have been spoken to with respect to both physicians, to nurses, to paramedics, and all of the things that we're talking about here. I mean, there's no one thing. It is a true system. So I think broadly, yes, we have a system, and specifically we work very hard to make sure that we do the best that we can for Nova Scotians.
Emily Burrows, do you want Dr. Boutlier to comment?
Only if you wish to.
Dr. Boutlier.
Sure. I think that I can say that the physician leaders in the province, both the zone medical executive directors and the department heads for emergency medicine and the site leads, it is a 24/7 job. Keeping everything staffed and making sure we have the best situation every single day for the people of the province that we have with the resources that we have. Christmas time is always a stressful time for us because people, are busy. People it's the start of the respiratory season and things like that. And I can tell you that there won't be many people on my team that get a break over Christmas, and both working in and trying to keep them staffed. And that's, and they do miraculous things every day to make the most of the resources they have. So I just wanted to take the opportunity to shout out my colleagues who do these leadership jobs, not because they are better than their day job of working in healthcare, but because they care about their communities and put their time into making the best for the community that they can.
Emily Burrow.
Thank you. Well, I think this point, Ms. Oldfield, you've made that retaining people has an awful lot to do with people being well treated at a deep structural level. I think this is really true. I think it's a key issue throughout healthcare provision in the province. I'm thinking about the vacancy rate for a moment in both of the health authorities. I understand that the current rate is over 5% higher than it was 2 years ago, and I'm wondering what does this say about overall in the authorities where we are with morale, job satisfaction, and working conditions.
Ms. Oldfield.
I think the real answer comes from data. I'm just getting Matt to check on the 5%. I can talk about nursing vacancies, and I can talk about all of those things, and I will if that's what you like. I would just like to share an anecdote, however, prefaced by the fact that Nova Scotia Health has not done an employee engagement survey since 2019, and that is on the agenda to be done for these very reasons. And so I first went around the province in September of 2021 on the Premier's Speak Up for Healthcare tour, and I was really very worried and concerned about what I was hearing around the province, but definitely in the Western Zone. And particularly on that particular tour at Yarmouth Regional Hospital, the morale was really poor. It was very evident, and I mean, that's a fact. So I went around the province. I visited all zones since July, but the most recent visit, as I mentioned, was the Western Zone 3 weeks ago. And I went to Roseway, Yarmouth, Digby, Bear River, Annapolis, Soldiers, Valley. And I will tell you that it was night and day. So that's 2 years, pretty much. It was night and day. This is anecdotal. This is not data, but there were changes in leadership. People were still working in very difficult circumstances. There's no silver bullet, but the morale was so much better. And I was in as many nursing units that I could possibly visit. Okay, and many travel nurses, you know, helping to keep our system functioning. But I want to clearly say I was so pleased with what I experienced, just with morale. And so, again, anecdotal, and not everybody's happy. There's no question about that. But as a general principle, it was a night and day tour on that particular trip, and I was very, very pleased to see it.
MLA Barrow with 1 minute left.
Yeah, well, just wanted to ask you about the Premier's contest for healthcare ideas that don't cost anything. I think this caused a lot of eye-rolling amongst healthcare policy people across the country. In the few seconds we have left, could either you from the Health Authority or from the department tell us how many actionable ideas have actually been generated by this project?
Ms. Oldfield.
So there were 2,200 ideas generated. I was thrilled to see that, frankly. I mean, we could call it a gimmick, but I think people really enjoyed it. They liked it. They did it, okay? And I've seen a quick run-through of the I guess, initial group, and it's all healthcare professionals, up to and including surgeons. Okay, so this isn't, you know, it's the whole gamut. So people actually took the time and they answered the questions.
And MLA Palmer.
Thanks, Chair. Most of my questions have been answered as well here by this great conversation, but I just want to maybe make a couple comments, and what might lead to one of my questions. A big shout out to Mid-Valley Physician Recruitment and Retention Group in the Valley, who's doing some great things. I know a lot of you have heard me talk about them quite a bit, doing great things from Aylesford to the Bridgetown area, and a lot of cultural events, like you mentioned. So there's a lot of great community groups, volunteer groups doing some wonderful things to retain doctors in our rural communities. I also want to thank my colleague across the table and the discussion we've had around Soldiers Memorial today. I know a lot of you have been raising the flag at Soldiers, even though it's not in my constituency. It definitely serves a lot of my constituency. And it's, you know, one of the things that I'm encouraged about is the improvement in information getting through to community. A lot of times that's been one of the concerns in the past, is when information isn't there, there's an old expression, you know, when the facts aren't there, all opinions are valid, right? So there's been a real improvement in communication to community. So I do want to applaud you for that as well. And also thank you for the visit to come to our area. We want to continue to make sure that that's highlighted our area for sure. But I also want to maybe ask about the, you mentioned that a new physician will be hired out of Valley, will be coming to Middleton to help stabilize the ER times there, which has definitely seen more consistency, which is something the community has been hoping for. We've already talked about the incentive program, but that in particular, Doctor, could I just ask a little bit how that's come together? About you mentioned that earlier in maybe in our conversation.
Do you mean Dr. Butler? We have a couple doctors.
You mentioned something about a physician.
Emily Palmer, over here. Oh, yeah. Which doctor? We have a couple at the table.
Well, I couldn't. I'm not sure who made the comment about that. It might have been you, Ms. Oldfield. If you could just.
Ms. Oldfield.
Yeah.
Just need to clarify the question. Where are they coming from, or to tell you about that doctor, or
about how that's come together, and you said also it's reflective of the incentive.
Emily Palmer, as you can see, as I said, try again.
Okay.
Dr. Butler, which is who I thought.
So I think what we were referring to is, like, in the new contract, there's an ability to try to create some hub and spoke models where people can be with other emergency physicians in different situations when they work at like a regional center, and then they can share their skills with some of the community sites. So within the contract, there's an ability to have an incentive to sign on for more than one site. So really what it does is it stabilizes the workforce in the regional, where people tend to want to go to work for a variety of reasons, and not least of which is having like a whole group of people to interact with in terms of the same job, but also to kind of help and go in and supplement the physicians that are in the community and doing emerge as well. So it's kind of trying to create what we're calling hub and spoke models of emergency care, and ideally what we would see is the people that as we hire new folks, they would sign on to this, and we would get sort of a stable rotation of people that are available to go to the communities.
Emily Palmer.
Thank you. And again, the conversation today has really highlighted for me one of the situations I think we all have, and that's educating our constituents and our citizens on what we are doing and what's happening, and all the initiatives we're doing. I mean, I did a series of town halls in my constituency, and one of the big topics was healthcare. And the comments we hear are, I didn't know you guys did that. I didn't know. And I think it's incumbent upon all of us around this table to make sure that we're all part of getting that information out there to constituents, so people are definitely informed of what all the options and the things that are happening in healthcare. And one last little plug for a physician assistant at Valley Regional Hospital. There for that. That'd be great. I'll pass it over to my colleague, MLA White.
MLA White.
Thank you, Chair. Thank you, Chris. So last year, government received the Golden Scissors Award from the Canadian Federation of Independent Business. That's a prestigious award that's given to politicians, public servants, different Canadians that make a real effort in cutting red tape. So I'm wondering if you can tell us what specific actions were taken to reduce the unnecessary administration burden by doctors and how effective they were.
Deputy Minister Lagasse.
Thank you, Mr. Chair. I'd first like to start by saying that a lot of this work that we're doing related to red tape reduction is done with our colleagues at with Deputy Minister Fred Crooks and the Office of Regulatory Affairs and Service Effectiveness. They've been fabulous partners with us in this work. And currently, we're targeting, and we have a number of initiatives that have been identified that will hopefully reduce physician burden by about 400,000 hours by the end of 2024. So we're around, I think, 200,000 right now that we've kind of hit that target during this year. But a number of different initiatives have resulted in those numbers, and big ones being the reduction of sick notes being asked for. There's a number of forms that have been redone and streamlined, leaned down, a lot of them being doing insurance forms, workers' compensation, Department of Community Services. So there's also a number of departments that are involved in this work, not just health and wellness and Office of Regulatory Affairs and Service Effectiveness, that it's been very good. And then the other one would be relating to our pharmacists have always had a very large scope of practice here in Nova Scotia, but we're now using that to its full extent. And by having pharmacists operating to their full extent of their practice, we've been able to achieve a number of other hours of burden reduction.
MLA White.
Thank you. How has reducing that administration burden, how has that impacted doctors' ability to see patients?
Dr. Bootler, everybody keeps looking at you.
Dr. O'Dane.
Dr. O'Dane.
Is that for me? Okay.
Okay.
Well, I think that it's an amazing initiative. From Doctors Nova Scotia point of view, the biggest impact it's going to have in the immediate term is in terms of wellness. It's going to allow them time to spend with their families. A lot of that work happens on evenings and weekends when they wouldn't be seeing patients to begin with. I'm hopeful that in the long term, as people free up more time, that it will also amount to more patient visits. It's really hard to quantify that at this point. I think shortening the forms means you get more forms done, but you're still spending 2 hours doing forms, but it's still an improvement. So I think that'll take some time before we know exactly what the extent of it is, but it's that unnecessary paperwork is definitely a burden, and Nova Scotia is leading the way. I know that across the country they're taking notice and looking carefully at the work that we're doing here in that regard.
MLA White with a little over 2 minutes left.
Thank you. Unapologetically proud Cape Bretoner. We have over 400 cardiac arrests a year and 500 heart failures. To say that I'm proud to be part of a government that announced a cardiac cath lab in Cape Breton Regional Hospital would be an understatement. So I'm just wondering if you can take a few minutes that we have left to tell us about how that lab is going to help and what extent it'll be for Cape Bretoners.
Ms. Oldfield with 2 minutes left, roughly.
Sure, thank you. So it was a very exciting day when that was announced, and a very important thing for Cape Breton. It started in the spring, and we are looking at 27, 28 for that to be up and running. So it will definitely improve patient outcomes locally. People won't be being carted into Halifax, and it will reduce wait times for cardiac services provincially, and it will free up hospital beds. I think one of the biggest things is that Cape Bretoners, even you, will be able to receive treatment closer to home. And that can never be underestimated, and it means fewer costs. It means so much more comfort being in your home community. So at the end of the day, it will be a better outcome for Cape Bretoners and for Nova Scotia. So yes, very important announcement and a very important addition to our healthcare system on the island.
MLA White with 30 seconds.
30 seconds, I'll say this. Long-term care is healthcare. All the beds that we're announcing around the province, how's it have an impact on the beds in the hospital?
Ms. Oldfield, 29 seconds.
We have 500 ALC patients in the hospital, and the sooner we can get them out to a long-term care, if that's where they need to be, then the freer our hospital will be.
All right, I'm going to call that with 9 seconds. So who has closing remarks? Okay, so I'm going to start with Dr. O'Dane, since I finished with him. Save his voice. Dr. O'Dane.
I just wanted to thank you for giving me the opportunity to speak here. I wanted to say that I think that we are making strides with primary care and emergency room closures, but it's going to take some time, and we need to be patient with that. I also think there's more that can be done, and hopefully we'll work towards that. I also wanted to apologize to MLA Di Costanzo because I didn't quite understand what she was getting at with the return for service contracts, and just quickly to say that I think that the return for service is for a different reason, because I don't think the problem in Central Zone is attracting people to Central Zone to work. The problem, at least with the family physicians that I spoke to, they're not leaving Central Zone. They're just leaving primary care, the longitudinal family medicine, and they've gone to do other things. I encounter them in the OR where they're doing things like surgical assists, and they've given up their family practices. They're not gone, most of them. They're still here, and the incentives that I think that are in the new long-term longitudinal family medicine model will hopefully, at least the feedback they've given me, will make it more likely for them to return to that type of practice or not leave it in the first place.
Ms. Oldfield?
Thank you. And just to conclude, you know, a tip of the hat to all of our ER physicians and staff and across the system. I mean, they've been working tirelessly for Nova Scotians, and I want to acknowledge that and thank them for their service.
Deputy Minister Grasse, anything?
Thank you, Mr. Chair. Just thank you for having us here today. And I think, you know, we've come a number of times that CEO Oldfield and I are usually here together, which I think, again, and we talk all about the whole of system, right? And I think a number of the questions that came out today and a number of the answers that we've given really do show that this is a whole of system response that's required. We can talk about a specific issue, but it really is all of the various initiatives that that are underway that will help us solve these very, very complex problems. So thank you very much.
I'd like to thank you all for being here. You're all excused. We have some committee business. However, we're going to take a 3-minute, so 2:46:40. Everybody will be back. So we'll just take a 3-minute adjournment. We're adjourned. Or in a recess, I should say, sorry. Yeah.
So.
put the mic on. Order. Okay, call the meeting back to order. We have committee business. We have a motion that was left on the table. And for Hansard, I'm going to read it as that the chair write on behalf of the committee to the Minister of Health and Wellness, to the acting CEO, Nova Scotia Health Authority, and the CEO, IWK Health Centre, to let them know what we heard about the need for Mi'kmaq represented higher levels of the health system and asking for an update on the hiring practices of what we discussed. So that is the motion as it was amended. So any discussion on the amended motion? Okay, all in favor, aye. Aye. Contrary, nay. Motion is passed. MLA Regan, you had a motion that you were going to send off that was discussed.
So we had discussed.
Okay, one sec. MLA Regan.
Sorry, apologize. I had indicated I wanted to make a motion about what we heard at last meeting's meeting. And so this is relating to that, sort of what we heard from the various witnesses on that particular date.
So this is the motion that you were talking that was long that you were bringing forward?
Yeah.
Okay, so,
Should we read it?
well, it has to be read for the record. So
I'm so sorry.
that's no problem, MLA Regan, because it's better for everybody who have read it. Has everybody had at least one chance to read it before? No. Okay, so if you want to speak about it and not to the motion right now, MLA Regan, then as soon as they're ready, then we'll do the move, if that's okay.
Okay, do you want me to read the motion?
Well, just a sec, why don't we just,
Let her read it.
you read the motion.
Okay.
So MLA Regan.
So I move that the Health Committee direct the chair of the committee to send a letter to the Minister of Seniors and Long-Term Care outlining what we heard at last month's meeting. The letter should note that we understand next year's budget is being prepared, and we want to bring these recommendations made by our witnesses directly to the Minister's attention. This letter should outline the committee heard compelling cases for the following improvements to the system, specifically that 1, to improve the health and safety of Nova Scotia's home care workers and clients. Timely in-person home assessments should be completed prior to initial care visits. Those first home care visits should be performed by a team of 2 home care workers. Until such time as cell service is extended to the entire province, in areas where cell phone service is currently non-existent or unreliable, tracking tags be provided so the locations of workers are known to their employers. Nurse practitioners be hired to ensure clients receiving home care who are not attached to a family practice can receive the timely health care they need, and an increase to the budget of Aware NS be included in the upcoming budget. 2, to improve retention and ensure the home care system is not being underwritten financially by our home care workers, home care providers, companies and organizations, be required to schedule and pay for continuous hours of work to those workers providing this care, and an increase to the vehicle allowance be provided to home care workers using their own vehicles to ferry them to each home care client location.
So it's your motion, so if you want to speak to it.
So, I think we did hear.
Oh, sorry, MLA Regan.
I apologize.
That was mine, but they realized. So MLA Regan, go ahead.
I'm so bad at this. Just, this is what we heard from our witnesses last month. They were pretty open about what was going on, about the health and safety of our workers, nurses, and CCAs, and also the fact that really the people who are doing those home visits, we're balancing the books on the backs of those CCAs. They are not being fairly compensated for using their own cars. So those are basically the reasons, the short version, those are the reasons why, that's what I took away from that meeting.
Any other discussion?
And we just want to bring it to the minister's attention.
Any other discussion? MLA Di Costanzo?
No, just if we can agree to send a letter, and that is exactly what was said here. So we can go back to Hansard if you wanted to make sure. It'll be good to give her this side, these points that we're here as a team sending this information. Thank you.
Any other discussion? Oh, well, MLA Young.
I'm just so I understand this here lengthy motion, Mr. Chair. So what we're asking is to get an update on things that were discussed last meeting, on things that the department's doing. Is that what you're asking?
I'm gonna allow MLA Regan to comment on on the motion as it's on the floor. So, MLA Regan.
I think the second sentence, the letter should note, we understand next year's budget is being prepared and we want to bring these recommendations made by our witnesses directly to the minister's attention. That's all. That's what we're asking. We want to make sure that she knows this is what they said at committee.
MLA Young. Oh, sorry, MLA Barkos.
I'm just wondering, sorry, I just handed my thing to somebody else. I'm just wondering, I'd like to deal with this at the next one. We were given to this 5 minutes ago. I want to read it, but I want to check my notes at home. And I have some meetings coming up with some people that actually do this for a living. So I'd like to, I would like to table this till next meeting. Please, thank you.
So just for clarity, are you moving to table this until the January 9th meeting?
Yes.
Okay.
No discussion.
Yeah, I'm just making sure. Okay, he's keeping me in line. So it's a motion to table. All in favor? Aye. Aye. Contrary? Nay. Okay, the motion is successful. It will be tabled and be on the January 9th agenda. And just for clarity, the ledge was confirming with me it was non-debatable. That's why I didn't ask. Any other business? Okay. Next meeting, Tuesday, January 9th, 2024, from 1 to, I believe, 3, is it 1 to 2 p.m.?
It's 2 p.m. It's an agenda setting.
Oh, okay, so hold on. So if this is an agenda setting, are agenda settings in public?
They are public, but they're only 1 hour long.
Okay, so this motion will be on the agenda for that, or, okay, just looking at, so this will still be on the January 9th meeting from 1 p.m. to 2 p.m. It's agenda setting. Any questions? All right, then this meeting is, oh.
The committee can decide to make it a 2-hour meeting if they want.
Okay, so I'm being told that. No. Okay, I'll leave it alone. Just all right. So I'll do what I was about to say. The meeting's adjourned.